Good evening and welcome to The Right Side, the show where we talk about today's news, views, trends, and opinions from an admittedly conservative perspective. I'm your host, Chris Pareja, and this evening we're joined by Dr. Beth Haynes. She's the Executive Director of the Benjamin Rush Institute, a healthcare policy expert and advocate, and we're going to be speaking with her a little bit this evening about Obamacare, the Affordable Care Act, and other things regarding how things may roll out for us in healthcare in the country over the next several years. Beth, thanks for joining us.
Thanks for having me.
So tell us a little bit about your background and how you got involved in wanting to analyze policy that other people just are afraid to even look at because it can be daunting.
It sure can be. Well, I've always been interested in economics and politics and really the ethics behind both of those fields, even during my medical training. So I trained initially as a family practitioner, did that for 1 year and then moved out to California, worked some rural ERs and fell in love with emergency medicine, did that for 20 years. I took a break to take care of some terminally ill family members, as well as was homeschooling my kids at the time. And when I started to get back in, I was going to do a cash practice in palliative care, and they passed the Affordable Care Act. And when I just couldn't even believe this country would consider that type of piece of legislation, let alone pass it, and was completely appalled by the lack of discussion anyone had on any side about how it was going to affect the doctor-patient relationship. And it was so clear to me that it was going to just drive a huge wedge between the doctor and the patient. And that's bad for patients, it's bad for doctors, it's bad for healthcare. Yeah. And so I wanted to just, instead of going and helping a few patients in my local community, I wanted to really do whatever I could to at least upgrade the conversation that we were having about healthcare in this country.
Right. Well, you called it a piece of legislation. Others have called it a piece of something else. But tell me a little bit about some examples that caused you particular concern and how it was going to depreciate the quality of care.
Well, nobody really was happy with what was going on in the United States at the time before Obamacare. Something had to change. We were seeing costs keep going up, and the two main economic actors in that transaction of the doctor and the patient knew the least about the cost. They were protected. Nobody cared about that. So people were making decisions that really were not cost-effective, value-oriented. And you could see that happening. And a lot of that had to do with how much third-party payers were being involved, both government third-party payers in Medicare, Medicaid, and the variety of programs that they have, but also the way the insurance has been encouraged to be very robust first-dollar coverage. And that with the third-party payer getting in between the doctor and the patient, we were already having trouble with that. And Obamacare took what was wrong with that previous system and doubled down on it. They gave more power to the government third parties. They gave more power to the insurance as third parties, and they gave much less control and choice to individual doctors and patients.
Right. And we're spoiled in this country. We expect that the doctor and the patient are going to be able to get together and going to be able to provide the service that is desired, whether sometimes it may be less necessary than others, but people like those choices, and you were seeing limitations or barriers being put up for that.
Right. There's more hoops that doctors have to jump through to be able to get the patients the kind of care that they want, to talk to the payers. Again, I mean, it has to be paid for somehow.
Right.
Nothing's for free.
Right.
But the control has been taken more and more away from the doctor and the patient. A lot of that's because so many of the dollars are being funneled through these premiums, through taxes, rather than keeping it at a much more normal kind of interaction,
right.
Economic interaction.
And what's interesting is we're talking about paying for health care benefits. And we had an interesting discussion right before the show about, people think that health insurance is the only way that things are going to get paid for, but you were delineating a little difference between health care insurance and then some of these other programs that are out there that really aren't insurance, but people assume are.
Most of what we call insurance isn't insurance. I mean, there's no homeowners insurance crisis in the country, and part of that is because it's actually insurance, and we don't have healthcare insurance. Insurance is supposed to protect you against catastrophic, rare, unusual, unpredictable events. That's how we pay for auto insurance, homeowners insurance, all those things. And you hope to goodness you never have to use your insurance. Because that means something terrible has happened. And just like we don't pay for oil changes with our auto insurance or our yard care through our homeowners insurance, there's these routine interactions between a doctor and a patient, predictable, small cost items that are no longer small cost because of being put through the insurance mill and all the administrative costs that gets added onto that.
Right. And you talk about the administrative aspects. You talk about the increased cost. Is one of the things that you're fighting for in all of your policy analysis, have you come up with ways to possibly reduce the administration and cost, or have you put thoughts out there? I know you don't necessarily write policy, but...
No, but one of the concerns I have about the Affordable Care Act is it basically says if you want to avoid the tax penalty, you can't just purchase catastrophic care. You can't just purchase real insurance. You have to have this very bloated, exaggerated coverage package that actually makes, the biggest part of the problem was causing healthcare costs go up. And keeping it so nobody knows what anything actually is costing them at the time of the point of decision of making is this worth it or not? Is this the right use of our resources? So I just lost my train of thought.
No, that's okay. We'll have that looked at medically, and you'll be billed heavily for it. It'll be fine. So, a question then. You know, you've been analyzing some of the various programs that are out there, and I know that it can get blurry when you're trying to figure out who does what.
So there are things that what we can do. There's an exciting new thing that if we just don't crush it, if we allow it to happen, called direct primary care. It's a form of membership medicine. So there's concierge, where you pay for extra access, but you're also paying your insurance premiums and so forth. And then there's direct primary care for $50 a month. You can go and have 26 office visits a year to see your primary care doctor. Everything they do in their office is at no extra charge. And that could be things like stitch repair. That could be EKGs, uncasting a broken arm. All sorts of things that your primary care doctor could do would be no extra charge to you. It's incredibly affordable. But you also need that catastrophic insurance, which has, in a sense, been outlawed, to have that full package. There's some creative ways that we can get around some of that, working with employers who self-fund, designing that package, combining it with direct primary care. But that's one of the really exciting options, that what we want to do is make sure those things are allowed to really blossom and flourish.
So it sounds like you're interested in free market solutions and having people just have an affordable relationship with their doctor.
Crowdsourcing the problem. Instead of having a group of experts, so-called experts, trying to come up with a plan that is going to work for the rest of us.
Right.
Really allowing all these entrepreneurs loose to invent, experiment, to have doctors and patients be able to contract together of what kind of care, what's most valuable to them. What are the services? There's one doctor up in Oregon that held a medical town hall, Pamela Weibel, and just said to her community, what do you want from me as a doctor? And she built her whole practice around that.
And then she was quickly outlawed afterward?
She's not outlawed, but some, you know, I don't know if she takes insurance or not, but my guess is a lot of these more innovative physicians are not taking insurance because of the cost and the hassle, and it becomes so much more expensive. Most doctors that quit taking insurance have their overhead drop by 40 to 50%.
And so they can reduce their costs.
Absolutely, absolutely. Or increase the time that they spend with you. Because a lot of the times that people aren't able to see their doctors, you know, they see them for 8-15 minutes, it's because in order to even pay the bills and keep the lights on, doctors have to see more and more patients now.
Extremely high volume. And in doing so, they might actually miss a symptom that would make the diagnosis more effective.
It's not good for the patients. The patients don't really get time to sit and talk with the doctor and feel really heard. It's also really horrible for the doctor. Doctors don't want to miss things, but they also don't want to miss that personal interaction that's going on. And what we're finding is more and more doctors are dissatisfied with the practice of medicine and leaving it early, a lot because of all the added clerical work that's being required to do quality reporting that isn't even been shown to actually be true quality.
Right. And so, and what you've talked about previously as well is that these experts, the so-called experts, are often not the patients or the doctors that would be impacted by the care.
They're really not. They're really not. And if the government goes and tries to learn from doctors, often, a lot of times it's academic physicians who aren't in the same, it's not they're not real doctors, of course they're real doctors, but they're not,
paper says so.
They're not in the same kind of situation as a community physician, a small practice, solo practice, private physician. It's just very different. So these systems that have been designed for, tertiary care centers, high volume, multiple specialties, trying to get all the doctors to come in together where it's easier to control them.
Mm-hmm. And so some of these policies that are being crafted that you've been reviewing, are they going to do anything to protect the solo practicing doctor?
No, exact opposite.
It's either you're going to survive by being acquired or you're going to leave medicine. Those are the two options that seem most prevalent right now.
Yeah, it used to be somewhere around 40% were independent physicians. Now almost 75% of doctors have their practices owned by hospitals or large groups. Right. So we've seen a tremendous drop-off on the small practice independent physicians, and it's because the reporting requirements, the electronic medical record requirements that have been placed on them, or they suffer penalties in payment from the government primarily, but all the insurance peg their payments to what Medicare pays. So they've seen their pay drop, and then all the administrative work, reporting requirements have gone up, and they just can't afford to stay open anymore. So they sell the practice.
Right. And doctors are often, they love people, computers not so much, and if you're going to force them also to go to that electronic route, you'll lose some as well.
Well, what's interesting is the doctors who were developing their own electronic medical records prior to the high-tech, high-tech was part of the stimulus before Obamacare, and that's where they started giving doctors bonuses to purchase electronic medical records, and initially there were these carrots, but now it's going to be, you're penalized very heavily if you don't have one in place. But the doctors that built or purchased the electronic medical records prior to all the requirements that came through that legislation love them because they were built around the clinical practice. Or if you talk to doctors who are purchasing electronic medical records within this direct primary care system, those systems, they don't have to report to the government. They don't have to report to insurance companies. So it services the doctors and the patient's communication. They love it. The problem with electronic medical systems and why so many doctors hate them is they're really, again, they're reporting quality measures, they're billing instruments, and doctors have become clerks.
Right.
50% of a doctor's day is typically spent doing paperwork, which includes, of course, the electronic medical records now.
So tell us a little bit about where Dr. Beth ends and where Benjamin Rush Institute begins, or how intermingled are they in the things that you do? I mean, these are a lot of the things that you've seen out there.
Yeah.
Talk to us about the Institute and what you're fighting to do through the Institute.
Sure. So I'm not seeing patients anymore because, again, I saw that probably the biggest danger to people's health now is really the trend in healthcare policy. And then I got the offer to go work with medical students. And I'll tell you that medical students are bright, are enthusiastic, they're full of energy. They're still in the stage where they have the energy and the interest of wanting to change the world and take on the world.
Until the government comes in and smashes them.
But they see their older colleagues getting beat down, and they're thinking, and most physicians would not recommend to their own children to go into medicine because of the changes that have gone on. but these students are really interested in looking for solutions. So Benjamin Rush Institute works with medical students to help them set up chapters on their campuses, and we support them to bring in speakers, to hold debates, have panel discussions about all the aspects of medicine that's not medicine, because they're not taught healthcare policy, they're not taught business in medical school. They've got a full curriculum without it. So the students will come across us word of mouth, or they'll get so frustrated because the little bit of policy that they get in their schools is all the government is the full answer. And so there's conservative libertarian students that say, I know there's more to it than this. And we support them bringing that information onto campus because it doesn't exist without us.
And so how does it work for them? Do some of them end up going more in advocacy direction once they get bit by the bug that's gotten a hold of you? Or do they just usually do this after hours to fight for the practices that they're trying to found to have a playing field that they can succeed on?
It's a mix.
Okay.
It's a mix. So there's some of the students who first learn about the direct primary care through the programs that we put on, or programs like Keith Smith's Surgery Center of Oklahoma, which is a cash-based ambulatory surgery center, where he has his prices like 1/10 to 1/7 of what the typical general hospital, not-for-profit down the street would be charging. They learn about this. They're exciting. It's high quality. It's low cost, and it's a way for us to get out from underneath all those papers. So they get excited about that practicing it. Some will do that.
How does that? I'm just curious. How does that doctor do what he's doing? Are you able to tell us at a high level? Is it a Willy Wonka secret recipe?
He says, so he's an ambulatory surgery center. It's physician-owned. And they take cash. Now, patients can come and they will submit the bill to their insurance. Keith's website has the prices. It's a bundled price. You say, I need to get my shoulder repaired, press on the shoulder. It'll give you that bundled price. And you go there, and that's the facility fee, the anesthesiology, the surgeon, everything you know up front. Right ahead. And he does it by, he has everybody that works there has an equity part of the stake in it. And so the janitors to the OR nurses, everybody, and they just work together as a team to make it as efficient and pleasant. I mean, you walk in the waiting room, and it's like somebody's living room, and it's just so inviting, and they have these special ways to handle kids to make it as low trauma as possible. And I mean, just the whole system is slick, and he keeps his costs really low. The other guy that's doing that is Debbie Shetty, who has got what is it, the City of Hope, or oh gosh, it's down in Cayman Islands, and he developed really efficient, high-quality, low-cost cardiac surgeries over in India because he wanted to be able to get something that the Indians could afford. Well, it's a doctor-owned facility. He can't build in the United States, so he built it in the Cayman Islands, and we have medical tourism there. So all is possible.
Well, and that's the thing, is you would think, well, if it was possible, the government would have done it already. Well, that's not what I would think, but you know, so, people may believe that.
So one of the deals that was made with the ACA was with the hospitals. And the hospital says, we'll come on, we'll take a cut in what we get reimbursed, but you need to keep these physician-owned hospitals out of the market. So no new physician-owned hospital is allowed to contract with Medicare. Any existing physician-owned hospitals who accept Medicare can't expand, or they'll lose their Medicare. So it was this real cronyism that has crushed that. Now, you can still exist. So there are physician-owned hospitals, but they can't take Medicare, Medicaid, any government dollars.
And you have to report to the government whenever you want to put a new bed in a place or anything else, right? There are a lot of... So
there's what is called certificate of needs, and not every state has this. And California, surprise, is actually one of the states that doesn't have certificate of need laws. But North Carolina, or...
And explain what certificate of need means.
So that means you have to go to the government to get permission to build a new hospital, to expand your hospital, to build a new X-ray facility. And part of that process is all of your competitors get to comment on whether they really need your services to come into the community or not.
Nothing could go wrong with that scenario, and I'm sure everyone can play fairly, and there's nothing political that could be motivated through anything like that.
Never.
Wow. And so what are your predictions for this next year to 2 years? We've heard a lot of wrestling about will the ACA be squashed? Will it be removed completely? Will it be gutted and replaced? What do you think is really going to happen? And we won't hold you to a guarantee, but it'd be nice.
I have no idea. I have no idea. So the Republicans are saying repeal and replace. That's very easy to do when they knew that there was no way that was going to happen with President Obama in office. Now the real and I think nobody really thought they were going to get the opportunity either. This November's election was a surprise to everybody. So we went from just kind of how do we claw back at the margins to make the ACA more livable and less destructive to, oh my goodness, we actually can maybe get rid of this and start over. On the other hand, I read somebody saying the ACA is kind of like kudzu. Do you know what kudzu is?
It just grows and grows and grows, and you can't maintain.
It roots into everything. And there are some real people who've been helped tremendously by the ACA. The problem is you can't just look at that one window of the people who've been helped, because the vast overall behemoth of the ACA is destructive. But what are we also going to do about those people who have gotten coverage now that didn't have it? That will need to be addressed. How they're going to do that, I don't know. I think there's some key principles that we can follow to make it better, but
yeah, I think the funniest reaction is the third one you didn't mention, and that's the Republicans going, oh crap, we didn't expect that we would actually have to do something with these promises, and then now they're going to have to deliver something.
Yeah. And it's all over the map.
Right.
It's all over the map of repeal and delay. Just repeal it right away. No, you can't. We just still need to tweak it. And I mean, I just don't know how those discussions are going to turn out.
Okay. And so if there were we have a couple of minutes left, if there were just one thing you could change with the way that healthcare is delivered right now, and I'll give you top three.
Okay. Okay. What I would do is make sure that we don't place any new obstacles to these really creative opportunities that are coming up, like direct primary care. Some states would treat that as insurance. We need to make sure we have laws in every state that says direct primary care is not insurance. It's just doctors and patients working. So we need to protect those, or the ambulatory, the surgery center, those castings. We need to make sure that those aren't crushed. I think policy-wise, the biggest change is what I call tax equality for all medical expenses.
Okay.
We have pre-existing conditions as a problem because your employer owns your insurance, not you.
Okay, so it's not portable.
It's not portable. And that's created the pre-existing condition. It's also created this really bloated overinsurance that we've had because of the tax advantage of that. So if every single dollar was treated the same tax-wise, then you could really start thinking about, well, do I want catastrophic plus an HSA, a savings account? So I think that would really open the creativity of solutions to how to pay for things. Okay, well, we are out of time, but I just want to give you a chance to is there a website where people can look up more of your thinking? Yeah, we didn't talk about Benjamin Rush that much because I know but the Benjamin Rush Institute is benjaminrushinstitute.org is the website. Perfect. We'll send people there. Thanks, Dr. Beth. If you hold on for just a moment, we'll be back after a word from our underwriters, the Conservative Forum.
Some people think that a meeting of conservatives in Silicon Valley could fit in a small room. In fact, when the Conservative Forum was founded in 2003, we did meet in a small room, a coffee shop in San Jose. It doesn't get more grassroots than this. It may surprise you that there are thousands of people right here in Silicon Valley who share your principles of liberty, free markets, and limited government. Since our humble beginnings in that coffee shop, we've outgrown 3 meeting halls. From San Jose to Gilroy to Mill Valley, we bring hundreds of people together each month from all over the Bay Area to promote the principles of American liberty. How do we do it? It starts with a stellar lineup of speakers. Speakers like Steve Forbes, Senator Jim DeMint, Dr. Victor Davis Hanson, Lieutenant Colonel Alan West, Andrew Breitbart, Pamela Geller, and many others. These speakers passionately articulate our shared principles and remind us why conservatism isn't just the smart choice, it's also the moral choice. Our monthly meetings are only one dimension of the forum. We underwrite The Right Side, a monthly television show on cable access channel KMVT. We also host a monthly Constitution discussion group and provide tables at our meetings for more than a dozen local groups who share our love of liberty to promote their specific cause. The Conservative Forum is the premier place in Silicon Valley for conservatives to gather, become invigorated, motivated, and empowered. We welcome guests to our monthly meetings and offer special discounted pricing to first-time visitors. Take a look at our speaker lineup in the coming months and join us to learn why we say liberty is made in America.
And that was a word from our underwriters, the Conservative Forum. We appreciate them greatly. They've actually made this show possible. This is the first show of the 6th season, and they've been with us the whole time, and we appreciate them tremendously. The other part that they're better known for, however, of their agenda of things they do to educate people in the Bay Area is the Conservative Forum Speakers Series. And that was one of the reasons we got to have Dr. Beth Haynes with us this evening. So, because she is one of the speakers that will be there this evening at 7 o'clock at the IFES Portuguese Hall at 432 Sterling Road, just a few minutes from here in Mountain View. And in February, Jason Riley, who's a member of the Wall Street Journal editorial board and senior fellow at the Manhattan Institute, will be there. In March, Lawrence McQuillan, a senior fellow at the Independent Institute, and other speakers coming up the rest of the year. Check the website for more information, and you can find that website at theconservativeforum.com. In closing, I'd just like you to take a few minutes, if you can, to visit the Benjamin Rush Institute, partially because we didn't get enough time to cover all of the information that's there that Beth had alluded to previously, but also you'll get more samples of her thinking and of her team's thinking and policy that you may want to pay attention to make informed decisions about who you need to harass and which office to get things done the way you'd like to see them done for improved quality of relationship and patient care in the medical space. On that note, I'd like to thank you for joining us. This has been the Conservative Forum. I'm your host, Chris Pareja, and I'll look forward to seeing you again in person or on the show sometime soon. But if you just can't wait, reach out to us at therightsidetv@gmail.com, and we'll try to answer any questions you have, catch any flaming darts. We promise not to throw them back, but we'll try to get anything that you need answered for you done as quickly as possible. Thanks again. Have a great night.